Okay. Good evening to everyone. I'm Dr. Onkar Swami on behalf of Emcure Pharmaceuticals Limited. Welcome you all in another interesting HIV update. Today we will be discussing on profiling syndromics, particularly COVID-19, tuberculosis, and HIV. And to take this session forward, we have very eminent faculty for today evening joining with us and who will be taking us through profiling syndromics, particularly for COVID-19, TB, and HIV. It's my privilege and honor to welcome and introduce Dr. S Satish, sir, who is currently working as in charge of pulmonary and HIV department at Fortis and Manipal Hospital, Bangalore. Sir is also president of Karnataka Pulmonologist Association. So it's very interesting to know sir has a very two critical and important specialization in pulmonology and HIV medicine. And sir has made an extraordinary contribution in both the streams of this medicine. He has more than 3 decades of experience in working in a medical faculty and holding a very important and senior positions. Sir has been a principal investigator for many clinical trials, for global clinical trials, I must say. And he is also involved into the research institutes, in a clinical research into the very prestigious institute of the country like NIMHANS and Jawaharlal Nehru Institute of Advanced Studies. Sir has been a renowned and most sought after speaker for national conference focused on chest diseases and HIV. Sir has conducted many CME programs and disseminated knowledge and experience that he gathered over the last 3 decades. And he's always an active faculty for many national and international conferences and medical updates. And he regularly conducts and participated in many television shows and interviews for the awareness, public awareness. So it's a really very nice to have Dr. K.S. Satish today to discussing on this important topic. So I will not take a much of time of yours between me, you and Dr. Satish sir. With this small introduction, I will stop here and I will hand over this session to our faculty and speaker, Dr. Satish sir, to take his lecture forward. Over to you, sir.
Thank you, Dr. Onkar, Balaji, Satya, and all my friends, and also the fellow participants who are watching this webinar. Thank you very much. Sorry, I was just on time because I was in another meeting. And as you said, it is a great opportunity for me to be a pulmonologist, to be also trained in medicine, general medicine, and also in HIV way back in 1988 in UK. So many of these viral diseases, viral epidemics that I have come across in my 3 decades, to be frank, now about 38 years of experience, has given me more confidence and has given me a lot of courage and scientific background to treat most of these. And that I will be dealing with how COVID came and then how it was not difficult at all. And I was chatting with someone recently saying how the similar kind of, especially with Omicron, which is there, or Omicron as it is called, that the similar kind of viral entry, the viral phase, and the conformational changes that we used to discuss in our HIV very early days is similar that we are seeing. So when I was asked to speak on this syndemic, as it's called, I think many people may not know what is syndemic. We know epidemic, we know endemicity, we know now about the pandemic. So syndemic is actually a synergistic kind of epidemic, which is an aggregation of 2 or more concurrent or sequential epidemic or diseases which are going on, and these are happening in cluster of population and for various biological interactions. It can be tuberculosis, HIV, what we are discussing, COVID, and also malaria. So these are all epidemics which are going on, and in a pandemic. So what happens to this? So it is a synergistic epidemic. Is the aggregation of two or more diseases which happen simultaneously. Okay, so let me start sharing my slides and then see what I can do here. Just give me a minute. Okay, let me start by showing some, one or two patients that I came across where there was overlap of all these problems, and then I can take you through the slides so it becomes easier. This is the case number 1, and the patient PJ is a 50-year-old patient, regular follow-up patient on antiretroviral therapy before the pandemic. And for some reason, he dropped out. And he's a patient who's educated. His son lives abroad, and then for some reason he didn't come at all. And what I heard from his wife was he took 15 days just to come and see me because he thought I will be angry and I will get wild against him because he stopped all his medication before that, and he came with very severe, serious sickness. He was very ill, barely able to move, and not slept, fever, weight loss, and he was coughing badly. And I said, okay, never mind. Sometimes these things happen. I gave him a lot of encouragement, a lot of courage. I said, there are new medications. You don't worry. We'll try to help you out. And then try to rule out all the opportunistic infection. And his CD4 was barely 6. And you can't believe somebody having a CD4 6, which we used to see in 1990s and very early days of 2000, but hardly anything after that. We diagnose early and we start treatment early, so we hardly see any patients with lower than 10 or a single digit. And so gave him a lot of psychological support, then a lot of dietary requirement that he needed. He is a vegetarian, put in a lot of protein and etc. And then ruled out all the opportunistic infection. And because he was on previous medication, I knew that he was going to fail and there was no time. So I started on darnavir, ritonavir combination and DTG. So he seemed to be okay, but he was unable to eat. So I asked my gastro colleague to put in a PEG tube and start feeding him. I told him a couple of months you require to have this PEG tube. So he was on a feeding tube. And so making some progress, but still very sick, because imagine with a CD4 count of 6 and then various drugs that I was giving. And so he was not very happy. And then he came one day with being very tired. And then as usual in the hospital, we wanted to get him admitted. So one of the protocol was to do a rat test, and it was positive. Then we did a RT-PCR test, and he was positive for COVID-19. So as per our discussion, they agreed because he was into very early phase of the disease, viral phase of the COVID-19. I'm talking about the COVID-19. And then they agreed to have a monoclonal antibody injection in the hospital. And then I said, since his oxygen, everything is fine and he's very early, so go back home. But they said, no, very difficult to take care of him. So you admit him in the hospital, and we got him admitted, not for any reason, because he received monoclonal antibody, and then to feed him, to look after him, and also give his antiretroviral medication. Every day I made sure that the hospital gave the medication that he was on, and also looked for opportunistic infection. He was on various prophylaxis with a CD4 of less than 6. But he was very sick. They became drowsy. His liver enzymes went up. His bilirubin was climbing to 8, 9. And then he was in liver failure, multi-organ failure. And then he developed encephalopathy, a lot of complications he developed. And then he expired just recently, about a few days back on Sunday. Fortunately, his son came to visit him, and he was very happy that he could see him before he died. So this is one such case where I'm driving this point. That's number one, stopping medication. After the pandemic started, there was no follow-up. Even though we were all available, the clinic was not closed at all. Probably he neglected his medication. He didn't take medication, didn't consult, and that led to lower CD4. And then he developed this COVID, which is a double whammy or a triple whammy for him. And then he progressed and probably died more than the COVID. He died of a combination of a severe immunodeficiency on top of COVID-19 disease. So this is one thing that we have to keep in mind: COVID, HIV, and other infections. That's one. And this is his X-ray. Nothing to remark here, but later he developed complication, hypoxemia. He was requiring very high oxygen. And then we decided not to put him on ventilator. The family also agreed on that. And then he died. That's one. The case number two is also, actually a patient who had during the second wave, Mr. S, non-diabetic. He was initially treated at home, but deteriorated during the second wave. He was admitted to the hospital close by in my care only, and then treated. And he required medication. He went home with a normal oxygen. He was in the hospital for a week, and then he was fine. So again, for some reason, he did not follow up. He thought it's all cured, and then he felt that he is fine, and then he didn't take any medications, and he was fine. I think he was, but he had mild symptoms of cough, and he was also slightly breathless and walking, and continued to lose weight. And he thought probably it's because of uncontrolled diabetes, for which he took the diabetes specialist opinion and started the insulin, but continued to lose weight, and he became hypoxic. And so he came to me, and then I said, there are bilateral infiltrates in the chest X-ray. Let's do some tests. And then the one that we do in a diabetic and post-COVID condition is to get a gene expert rule out tuberculosis, and as expected, he was positive for AFP by gene expert, and no rifampicin resistant. He was started on anti-TB medicine, seemed to be okay, and he was also on antifibrotic drugs and diabetes control, and he lost a lot of weight and muscle. He came recently, about a week, 10 days back, with severe hypoxia, and then we found that he had a massive pneumothorax. I admitted him again. It was a tension pneumothorax. He was very hypoxic, looked very sick, and put in an intercostal drainage. And then the lungs took some time, but it opened up nicely, and then he was better, so he got discharged. So here is, of course, a successful, but he still has a long way to go because his lungs are not great, as seen in this CT scan, which I did. Recently, the X-rays were showing bilateral infiltrations, suggestive of a combination of tuberculosis. There were three bud appearance, and also post-COVID condition. So this shows extensive consolidation, and then a pneumothorax which was healing on the left side. They put in a tube here, and then drained all the air, and then he went home. I saw him in the hospital before discharge. He said he will take the medication. He's on anti-TB medication, and kind of strict control of diet and diabetes, which is important for him. So this is yet another combination of a COVID, diabetes, and tuberculosis. So let me now, so these are two examples, then you will understand how these overlap can occur. Let me go back and see and take out the slides which are there. Okay. So this is profiling syndemics, and with that, it becomes easy for us to understand the COVID-19, tuberculosis, which is a common disease in the world, with nearly 1.4 million new cases reported every year from India. India houses 1/3 of the world's population of tuberculosis, very common. And of course, Africa and other parts of Russia and various other socio-economically challenged countries have a lot of tuberculosis burden. And HIV, of course, Southeast Asia and India with 1.8 to 2.4 million people living with HIV, and Africa and other countries where HIV is common. So when you have a COVID which has touched every nook and corner of this world, and there's no country which is devoid of reporting COVID. And when you have a combination of all these trio, it is not a double disease, it is a trio of tuberculosis, HIV, and COVID, then we have a big problem. So there was this raging coronavirus pandemic in the midst of the other epidemics which were going on. And this required a massive kind of effort and pulling out of all kinds of resources to help the pandemic. Most of us have not seen a pandemic. The last one was the Spanish one, and then before that was another pandemic. But we have seen the H1N1. It was not a pandemic. It was kind of an epidemic which was seen all over the world in pockets. So this led to what is known as the COVIDization of the health system, which means you pull out all kinds of resources that you have to face the pandemic, which has affected the whole world, and every country in this world was affected badly. And naturally, this effort led to a negative impact on some of the diseases that I mentioned, like tuberculosis and also malaria and also HIV. So the diagnostic repurposing and redirection of funding. So there was repurposing and what is repurposing? For example, we were using the same kit which is used, Gene Expert kit, which is used for tuberculosis, and many countries had to stop doing the Gene Expert and then was sent to doing, even now we do the CBNAT using the kit for COVID diagnosis. Redirecting fund, human resources, where all the healthcare workers and the paramedical workers, the outreach workers, and the other ASHA workers, for example, in India, all who are concentrating on the pandemic, and the coordinators of tuberculosis and HIV also were helping COVID pandemic. This was strongly experienced by the big three infectious diseases, tuberculosis, malaria, HIV, which cumulatively account for 2.4 million deaths worldwide in 2018. So that was a huge number of combination of this leading to huge mortality rates there. This pandemic potentially led not only in missing targets, which we were planning. For example, in HIV, we said we must have 90%, 90%, 90% diagnosis, treatment, and undetected viral load. That took a back seat, and also a lot of resources were missing during that time in doing the decades of monumental progress, especially in HIV and tuberculosis, especially in India, when the Prime Minister himself took the lead of saying that we must eliminate tuberculosis in India, if not by 2034, at least by 2024. He was even preponing it, but this all took a real battering. So the COVID pathophysiology is almost like the HIV viral disease, the viral phase, and then the inflammatory phase. I won't go into the details of this. And if you just see COVID-19 and HIV, what do they do? And like how we used to discuss about HIV and tuberculosis here, let's talk about HIV and COVID-19. Due to strict COVID lockdown measures, individuals were or may abstain from visiting healthcare, which happened in my patient and also many others. Unfortunately, we were available on online consultation and for diagnosis and treatment, which may also increase the incidence of HIV infection and interruption of the ART compliance. That is mainly because patients were scared, and then the hospital was overburdened, overwhelmed with the COVID patients. So there was some interruption of ART. And since the transport was shut down, many patients could not get access to the ART. As you know, the ART compliance is so important. Sorry. So patients missed many medications due to the interruption, especially the transport and things like that. And in our center, we made sure that patients received it. We sent it by all kinds of means of, they were vegetable vendors and vegetable transport, which was available from, for example, North Karnataka to Bangalore, which were allowed as essential services. And we used to send them medication through them and to deliver to the patient's door. And I remember there was a paper article about a person traveling by cycle about nearly 100 kilometers to deliver antiretroviral medication from North Karnataka. So these kind of things, helped the patients to receive, and many of them also missed medication. So there was a concern about increased risk of severe COVID-19 for people living with HIV, maybe based on assumption that they are more immunosuppressed. Under this rationale, particular caution was given, especially with the patients with low CD4 count and high viral load and patient not on antiretroviral treatment. So I honestly attended many webinars during that time. What is the impact of COVID on HIV? And patients who took regular treatment, whose CD4 was more than 200 or more than 500, whose viral load was undetectable, compliant patient did not have any extra risk of suffering from COVID illness and serious diseases. And as you know, patients with HIV also are prone for chronic diseases of the medical chronic diseases like diabetes, hypertension, high cholesterol, ischemic heart disease, and renal and hepatic disease. So they were also at risk for developing serious COVID-19 infection. And many studies came out during that time, especially from Spain, and they found no appreciable increase in serious complications of COVID when their CD4 count was more than 200 or even 500, and their viral load was undetectable and they were on medication. This is just a slide showing the SARS-CoV-2 and HIV. The SARS-CoV is a beta coronavirus. HIV is a lentivirus family, and almost similar in diameter. And here, the receptor binding domain is the AC receptor, And in CD4, we know about the receptor and co-receptor CCR5 and CXCR4. And these were the binding sites to attach. And then in HIV, it was lymphoid tissue, and here it affected the respiratory system, the heart, and then the other system as well. So adherence to ART as measured by patient reporting and direct pill counting was important, and those who pill count was dismal or who did not take developed complications of HIV and AIDS as well as COVID, and those who disrupted or treatment developed a severe COVID disease and other opportunistic infection. So this is a combination, this slide showing pathophysiology of SARS-CoV-2 and HIV infection. Here, many of these patients later, we found that especially COVID patients in the second wave who received higher dose of steroids, because the science was not so clear about the use of higher dose of steroids. We all used, of course, later very small doses of steroid, irrespective of the patient's severity of the COVID. And we use only now 8 milligram, 6 to 8 milligrams of dexamethasone and 40 milligram, similar to equivalent, irrespective of CRP, irrespective of patient's condition. But many treating doctors used higher doses. That led to another kind of an epidemic, which is in India, the aspergillosis or the black fungus. So that we used to see aspergillosis many years ago. In fact, late on early 2019, when we had no ART for patient, they developed all these complications of cryptococcus and aspergillosis in them. So we had a lot of experience in that. So similar kind of pro-inflammatory levels were elevated even in HIV infection during the inflammatory phase. IL-2, IL-6, IL-10, and interferon alpha were also elevated, and both are coagulable state. We are pro-coagulable state. As you know, in HIV, also the patients are prone for deep vein thrombosis and pulmonary embolism, complications due to heart because of the thrombotic complication, and so also in patients with SARS-CoV-2. What about the clinical presentation? Initially, both are almost same. They are viral diseases presenting with fever, cough, shortness of breath, and which were also reported by patients with HIV. Also, these are reported by patients with tuberculosis, except the shortness of breath, which did not happen. And to differentiate between, one is a short duration, the other one is a long kind of duration. For example, in patients with HIV, these patients had long history of breathlessness. So people co-infected with HIV and COVID-19, most of them had mild disease, where the PLWH patients were on regular treatment, but they had other risk factors like diabetes and hypertension. They developed complications similar to patients who did not have HIV and who had comorbidities with COVID-19. And of course, the age was also one of the reasons. So impact of antiretroviral HIV drugs, there were a lot of reports initially from abroad and from India about the protease, especially from China, where they did initially in Wuhan. They used the combination of protease inhibitors and ritonavir and lopinavir ritonavir, to be precise, and we showed some kind of response. And it was not scientifically documented. There was no randomized control study. It was all case reports. Even in India, especially from Jaipur, they said patient got benefited, and then there was a lot of media hype and media reporting of lopinavir ritonavir. Many physicians used that, but we later came to know that the dose that is required to suppress the COVID-19 virus was very high, huge. and in terms of nearly 100 times the normal that we use for patients with HIV infection. So that was removed and showed very clearly by the recovery and solidarity trials, which are one of the classic hallmark trials to know the effectiveness of lopinavir, ritonavir boosted combination. And there was something about darunavir, again, also stuck down because it was not really shown beneficial effect. There was some mention about including tenofovir was used. So the anti-HIV drugs did not really make any impact on COVID-19 infection, except that they preserved the immune system, and patients who had a preserved immune system did not suffer from severe COVID. So does HIV affect COVID-19 susceptibility or severity? There was some reporting that these patients are prone, even now mentioned that immunocompromised, but if they are on regular treatment, as I mentioned, and whose CD4 count is very good, they are like normal people who are at risk. So there was no particular kind of susceptibility of HIV patients for COVID, except when they had a lower CD4 count, and also their viral load was up, and they were not on medication. But other than that, nothing really. But it is mentioned even now that those who are immunocompromised, like HIV patients, are prone. But we must add here a rider that patients who are completely immuno recovered patient with HIV did not have any more susceptibility than the regular patient of COVID-19. So only the care was affected in the pandemic, as I mentioned about patients' lockdown measure, the travel restriction, the physical distancing, and so on and so forth, and which led to a problem. We will know the impact in the future. Let me now focus on COVID-19 and tuberculosis. Both tuberculosis and COVID-19 exhibit overlapping clinical signs and symptoms. I had many patients who could not come but had cough. They did not do an X-ray. As you know, 2 weeks of cough with a fever, we should do an X-ray and a sputum test. This was all not happening. They all thought that it was due to various kinds of diseases and never came to the hospital. And ultimately, when they did those tests for that, they were positive for tuberculosis. There was definitely a delay in diagnosis and treatment because of the restrictions and the scare that the COVID patients in the hospital would spread COVID to other patients. So this was badly affected, where we used to refer patients for sputum testing, chest X-ray, and various kind of tests which are required. So this was one of the setbacks during that time, and now slowly, we are seeing more and more patients who were missed because of patients not able to come to the hospital. The lung imaging in COVID and tuberculosis in the initial stages are similar. There can be cavity formation, there can be infiltration, there can be kind of tree in bud appearance, and so on and so forth. But COVID-19 has a typical finding. One look at a CT scan, you could make out that this is COVID and not anything else during a pandemic, of course. So there were nodules, there was other pleural effusion, uncommon in COVID-19 as a presentation. Cavities were known, infiltrations were known, cysts were also known in these patients. And many patients who did a CT scan for diagnosing COVID also picked up cavities, and they were diagnosed later as tuberculosis. There was also other inflammatory markers like CRP, ESR. They were also elevated in COVID as well as in tuberculosis patients. And very rarely, some of these are also reported to be high, like D dimer and so on. So the COVID TB biomarkers may provide reference for conventional hematological and inflammatory examination of the severity and classification of the disease. So in India, TB and COVID, this is important. And highlighting here, the prevalence of TB among COVID-19 patients has been found to be 0.37 and to 4.47 in different studies. There has been an overall decline in TB notification. Remember notification, because of not coming to the hospital and not approaching doctors for diagnosis, about 26% between January to June 2020, as compared to the previous year due to COVID pandemic. So in India, studies have also shown that the history of active as well as latent TB is an important risk factor for SARS-CoV, and tuberculosis is associated with 2.1-fold increased risk of severe COVID disease. In addition, TB patients also tend to have comorbid living conditions like diabetes, malnutrition, HIV, and so on. So this overlap was seen in India, and Indian government later came out saying that all patients who recovered from COVID or diagnosed with COVID, please screen them for tuberculosis, which I'm going to share some slides. So that's what the Ministry of Health said, bidirectional TB and COVID screening. TB screening for influenza like illness. So when they approached hospital, it was an opportunity to find out whether they had tuberculosis as well, because everybody with any kind of fever, any kind of respiratory symptoms later approached hospital for getting diagnosed, thinking that they have COVID-19. TB screening for severe SARI cases were also done. So the bidirectional TB COVID screening many a time helped to uncover tuberculosis. So this is how the algorithm goes. Diagnosed TB patient currently on TB treatment, testing for COVID-19. If COVID positive, treat like any other COVID, mild, moderate, and severe. COVID-19 negative, continue TB treatment. TB screening for COVID positive patients, which means COVID positive, screen for TB. That's the bidirectional screening. Chest X-ray or do an upfront the CB-NAT. Diagnosed with TB, treat them as TB, refer them to the TB centers or take care of them in your clinic. Not diagnosed with TB, follow up with the guidelines of Ministry of Health. So that's TB. And TB screening for ILI was similar. Any patient coming with ILI, screen for TB. So chest X-ray and CB-NAT, diagnosed with TB, treat them. Not diagnosed as TB, follow up with the guidelines which are there. It may be a COVID-19 or influenza that we are seeing more and more now during these months. Similarly, SARI cases also screen for TB, and similar algorithm holds good. This is from the Ministry of Health. So this also helps us in picking up more tuberculosis treatment, diagnosing early, putting them on treatment, and preventing the spread of COVID and as well as tuberculosis. So managing this TB and COVID infection is important. There may be some drug interactions like rifampicin and steroids, rifampicin and anticoagulation, and so on. And patients who are on injectable anti-TB medication, especially drug-resistant tuberculosis, try to see whether they can be on oral, because going to the hospital every day to take the injection may be time-consuming and also scaring, and patients' adherence to the treatment will definitely fall. So we have to also counsel patient. So what helped during the COVID was the telemedicine. My friends from Mumbai tell me that the patient liked it, and they said when they were called and then they sent the medicine or took the medicine, they said one thing is there was no wait. There was no coming to the hospital waiting for hours in the queue. There was no travel getting stuck in the traffic jams, and they really liked it. They said, you please continue the same thing. Anyway, you are monitoring. We are going to upload your the test that is required. and then the medicines are given, and then we do that. They really loved it, and the doctors also loved it. Probably it will become a means of, in the future, telemedicine of managing patients once they are diagnosed with tuberculosis, and they need not come to the hospital for monitoring side effects and taking the treatment. They loved it, and doctors also helped themselves by cutting down seeing physically patient during the pandemic. Of course, now patients are coming back, but they also ask for online consultation, teleconsultation, which is great for patients with tuberculosis, for monitoring these patients. So I help a lot of patients with telemedicine and treating them and monitoring the side effects. So this is going to stay, I think, in the future. In summary, we still do not have any proven antiviral agent that reduce mortality about COVID-19 patients. So there are no antiviral agents. Favipiravir came, and then not much strong evidence about it. And now molnupiravir, and also the Plovidax, which is there. So showing some kind of definite impact on this. A lot of studies are going on. Hopefully, they should help us. Right now, there's no antiviral COVID-19 medication except the cocktail antibody or monoclonal antibody. Several recommendations have been made on how countries can minimize the disruption caused by pandemic. So it's a big lesson for every country that how, in case there is any problem and then a lockdown or anything, how we should not disrupt any of these treatment which are going on. So the TB community needs to urgently embrace adaptations to COVID-19, using the momentum to re-energize efforts to end TB. So we should continue the same kind of vigor and the care that we took to end the TB. So we should not end TB effort that we did to prevent tuberculosis. Minimizing stigma and misinformation about COVID-19 is very important. People with HIV and TB have also experience in dealing with the stigma and can allege in preventing COVID-19 stigma. So all these are stigmatizing diseases. Patients still have stigma about tuberculosis. Patients still have about COVID-19. Much, much better now. Expect in the first wave that there were a lot of stigma about COVID-19. And that led to complications and late presentation. And of course, HIV continues to have stigma, which cannot be done. So I stop here and stop sharing my slides. And thank you very much for giving me an opportunity, the entire Emcure team. And they have always supported academic activities. I'm very happy to be a part of this webinar. And I also learned a lot about going through and sharing my experience about all three diseases, which I have been dealing for more than 3 decades, the HIV, tuberculosis, and other pulmonary diseases. Of course, the COVID-19 being part of the expert committee in the last 1.5 years or so. Thank you very much. And over to you, Dr. Onkar, for questions and so on. Shall I stop sharing the slides? Yes, done. Yeah, thank you.
Thank you very much, sir, for a very nice presentation and explaining in detail about this Syndemics. So there are a few questions, sir. We'll take one by one. There's a question by Dr. Parvati, rather a question. She's sharing an observation and then maybe your opinions on that. So in their center, out of 1,050 patients living with HIV on ART, from their center, 109 had a COVID infection. Only 2% on protease inhibitors became COVID positive. Those who are on ART, but no one on lopinavir and ritonavir has a COVID infection. Does it mean there is a drug has protected them?
Yeah, good question. As I said initially, it made a lot of noise. In fact, many companies stocked and even government procured lopinavir ritonavir combination. We were worried whether this will take away our patients who are on this drug, and then what will happen to our patients. And it was anyway short-term lopinavir ritonavir, but still when thousands and lakhs of patients require lopinavir ritonavir, we were really worried about it. And similarly with budesonide inhaler, I was also worried about it because it is recommended during the viral phase to use this combination of budesonide 1600 microgram. So doctor's observation is right, but it is shown by all the trials, including recovery trial and the solidarity trial, that it made no impact at all. Probably what has happened is those who are on this combination had a good response to the treatment of for HIV, and their immune status improved. Their viral load was driven to undetectable levels. They had a good immune recovery, and they were not prone for complications. That is what I can say. But definitely no now, after 1.5 years of practice in COVID and science in COVID, so we should not be using. And they found out that the dose which was required was very, very high, and it cannot be given to anyone, about 100 times higher than what is required. Yeah, that's good observation. Anyway, I think it's just that treatment helped patients to recover from the HIV, and they had good immune recovery, and then so they didn't develop any complications.
There's a question from Dr. V.H.T. Swami. What he says that currently rifabutin is not available. What's your suggestion of using alternative to treat tuberculosis who are on atazanavir-based regime?
Yeah, very good question. I had this problem yesterday. Somehow my pharmacist nearby found, he said exactly because it just happened yesterday, 15 strips, each strip containing 6. So I said 90 days, 90 tablets available. Anyway, we give alternate day 3 times a week. So this will cover for at least 6 months. So I was very happy. And he said, so I'll try and get some more. Yes, it's a problem. And the doctor is right. But we have to get that in case it's not available for patients who are on a protease inhibitor, then we have to go back and use a non-rifampicin based regimen. Yes, the problem is right. I had this problem just yesterday, and then I got it. My patient got it. Yeah, thanks.
So same doctor is asking, sir, recently we had a patient whose X-ray was showing miliary mottling and sputum AFB negative. His lymph nodes and FNSC showed histoplasmosis.
Yeah.
What's your opinion? Can we consider the test both or just treat with histoplasmosis?
Okay, very good, very interesting case. I've seen a couple of them in this part of my state. Not very common. Common in northeastern states. The reported histoplasmosis, and especially Nagaland, Mizoram, Assam, those kind of areas earlier. And it's not very common histoplasmosis, but picking up a histoplasmosis and treating that definitely is required. Also common in other countries like North American countries. There are places where histoplasmosis is common. Of course, in the presentation can be something like this. And what I've seen in just 2 patients that I had histoplasmosis, or maybe just 1, and then demonstrated in lymph node biopsy. So treat histoplasmosis, but also keep an eye on tuberculosis, because there can be, as you know, in HIV, you don't be happy, don't be satisfied with one diagnosis. There are always, we have found, especially those days in 1990s and 2000 when there was no ART, we have found tuberculosis, we have found histoplasmosis, or aspergillosis, or mucor, we have found CMV, we found pneumocystis caninpneumonia. We have found all in one single patient, 5 diseases in one. So here, keep looking for tuberculosis, because there's a miliary shadow. Miliary shadow, not very common with histoplasmosis. But if you get transbronchial lung biopsy, that will help. And if it shows granuloma and suggestive of tuberculosis, gene expert positive in the tissue sample, then you can treat. But keep looking for it. There's absolutely no problem in giving a trial, because we should not be missing tuberculosis in patient because it's curable disease, because histoplasma is not so common. Very interesting case, but keep looking for and send repeated samples if patient is not fit or not affordable for doing a transbronchial lung biopsy. Keep sending samples.
Thank you, sir. Thank you. Those who want to share their comments, thoughts, or maybe questions, they can put into the chat box, or even they can unmute themselves and ask to Dr. S Satish, sir. We welcome your questions. Sir, recently we have seen some European and maybe US has approved molnupiravir. And
Yeah.
India also, we are expecting this will be launched soon. The studies and everything is going on. So how you look forward for this development, sir?
Dr. Onkar, to be frank, I'm very excited, because at least there are a lot of trials and studies which have gone on and showing. Definitely, I've attended few webinars from US, Stanford, and also from India. And because there was also one or two Bangalore center, and I was approached for this study, but since the COVID cases were coming down, it came later in the second wave.
Yes.
Could not do, but has shown definitely very early stage of viral disease, viral phase of COVID-19. Definitely, it prevents serious COVID infection. It's not going to be helpful if you are using it when the oxygen is low, similar to cocktail antibody or serious illness. Definitely, it reduces the duration of illness and brings it down, and patients also recover faster. This is what I've heard in the clinical trials and in the webinar. Looking forward to it, because we only had Favipiravir repurposed drug again, and the scientific community was not very happy about, frankly, about the data and then about the outcome and so on. And the pill burden was also high. So hoping that molnupiravir, will help, like how we had oseltamivir for H1N1 and other influenza. Looking forward to it. Let's hope we'll have something like this to be given to patients during very early phase of COVID-19 infection.
So, thank you very much, sir. There is another question from Dr. Ravi Kiran. He is asking, have you seen more resistant tuberculosis and HIV due to logistical challenges?
Okay, so good question. My other friends have always said that, like in Mumbai and other places, that patients with HIV have a lot of multi-drug resistant tuberculosis. I'm not talking about during the pandemic, but for somehow my data and experience have shown, probably because I practice privately and patients can afford, and some are definitely educated, and we do a thorough counseling, and they take their medications regularly. And as you know, antiretroviral drugs are like a vaccine for patients with HIV to prevent tuberculosis. So I feel I haven't seen many patients with drug-resistant tuberculosis, frankly, in my practice. The government centers have reported, Mumbai has reported, other places have reported. I probably have maybe just a handful of cases where patients with HIV develop a drug-resistant tuberculosis, but not to the extent that I was alarmed and I was screening for everyone for it. Of course, the gene expert will help us. So my data and my experience is not so great as the others in terms of multi-drug resistant tuberculosis and HIV.
Thank you very much, sir. Those who want to interact with the sirs directly, so you can just unmute or you can raise your hand, and so that I can just take it forward, so that you can ask your questions directly to the sir, or you can put into the chat box also, and we can just always have that. So that's quite possible, because it was very exciting session and we are approaching towards the end of our discussion, but still somebody wants to have some discussions on the interactions or the comments. Please feel free to unmute yourself, and maybe you can share your thoughts, your opinion, your views. Okay. Okay, sir. We have quite a bit of participation, sir. We have more than 60 doctors across the country who are listening to this webinar. We are getting a lot of positive comments and appreciation for your lectures in the chat box. So I think we have come to the end of this session, and we have almost an hour's time discussing about these very interesting topics and the newer development. So, so thank you very much, sir. At the same time, our Executive Vice President, Mr. U.D. Balaji, sir, has also joined. So, sir, over to you for your final comments and maybe vote of thanks.
Thank you, Dr. Onkar and Dr. Satish. What a pleasure listening to you.
Thank you.
A really enriching experience, because today you have enriched our vocabulary by introducing us to a new word called as syndemic.
Syndemic.
We have never heard about this.
Yeah.
And this is certainly something that we will remember for a very long time, as it directly relates to the field of HIV and what we are dealing with on a day-to-day basis. The other thing that I should compliment you is that I would say that there would be hardly a very few doctors as brave as you to have handled this topic of a syndemic, where you have fused the challenges arising between HIV, TB, malaria with the current COVID situation or the pandemic that we are going through. And even among them who would have the knowledge, you have stood out and to come and share your experiences with real-time clinical evidence and insights and your interpretation. Outstanding, very, very outstanding work, sir.
Thank you.
We are really grateful to you for the time and your efforts in putting across this slide presentation and your insights. And it's also, you did touch upon certain challenges that patients were having during the pandemic, whether it was HIV patients or TB or other infectious diseases patients. So these are things that we have not actually, we are aware of, but others have not touched upon these practical things that confront our population. So thank you very much, sir. And really, it was our pleasure listening to you. And
but see, I must remember, your team who helped my patients in Nigeria to procure and to get the drug all the way, and then in Singapore, and then in UK, and then they were so happy. And I must share here, your team did not bother about the money. They said, let them first receive the consignment, because there were a lot of problems in transporting and then sending by courier and so on. So they were all very kind. They were all appreciative. They were all helping. I'm also very happy that your team helped my patients, especially in these countries and of course all over India. Thank you.
Sure, doctor. And it was during these times that we also adopted to the multi-month packing. If you see in all our products, whether it is right from Viropil to Inbec to Spegra, and all these products, we have come out with a multi-month, that is 3 months pack. Because the patient doesn't need to come back on a every monthly basis to replenish his stocks, because the prescriptions don't change on a month-to-month basis. These are long-term therapies. So this we thought would be helpful to them, not only in an administrative or a way, as you had told rightly, that patients doesn't need to spend long hours commuting or in the traffic. And also there is also a cost advantage to the patient when he's going for a multi-month pack. So these are certain things that we thought we should bring it to their benefit. So thank you once again from all of us, doctor, and I hope to be meeting you in person in the future.
Thank you.
Thank you very much. So we'll stop at this point of time. Thank you, everybody. We wish a good night and a happy time ahead. Thank you very much.
Good night. Thank you. Thank you for the whole team, Emcure team. Thank you.
Thank you, sir. Thank you.